Hello guys, welcome to today's video, and today we are on the seventh chapter of the guidebook, and this is where we're starting our neurology block. The neurology block is just two chapters, chapter 7 and chapter 8, and in today's chapter we'll be covering stroke, TIA, headaches, multiple sclerosis, and as achalasia as well. Alright, and to start off that, we'll be going over strokes, the different classifications, how do they appear, so if it's ischemic stroke versus hemorrhagic stroke, and which of them is most common. Alright, so start off that ischemic strokes are more common. They're seen in 80 to 85% of the cases, whereas hemorrhagic strokes are seen in just 15 to 20% of the cases. And remember that it is highly dependent on the symptoms plus the history that the patient has. Alright, now the CT appearance is going to be completely normal in the first 6 to 24 hours, and it evolves to hypodensity in ischemic stroke. Whereas for hemorrhagic stroke, we see it immediately. There's going to be blood visible within minutes. Then the management for ischemic stroke, and the importance of CT appearance is the fact that they could tell you that this person has a headache, comes in, their CT scan is completely normal. However, a few hours, they could give you an option and tell you that what's the next step. It could be that you repeat the CT in a few hours, or they could tell you that their CT becomes, they give you a hypodense, they could give you a hypodense description of their CT and tell you that this happens a few hours later. So that is ischemic stroke. Alright, now moving up to the management. The difference in management is that for ischemic, because it's a blockage, we use TPA if eligible, and it means that it has been less than 4.5 hours. There is hemorrhage excluded and the BP is less than 185 by 110. Whereas for hemorrhagic stroke, we do not give any BP, we don't give any TPA because it's a hemorrhage. We have to aim for getting the BP control, and neurosurgery should be done if it's indicated. Alright, and then moving on to BP, non-TPA. And then permissive, treat only if more than 220 by 120, because if you had to give them TPA, we had to get the BP below 185 by 110, and for hemorrhagic stroke we have to lower it a lot more. All right, and the reason for that is that most of the blood shouldn't just gush out from the hemorrhage that is taking place. That's why the aim of the hemorrhagic strokes BP is lesser than the ischemic stroke. All right, secondary prevention for ischemic stroke is going to be antiplatelets, aspirin plus dipyridamole or clopidogrel, or DOAC if there is AF in the patient. Then because AF can also lead to ischemic strokes, and for hemorrhagic strokes we treat the underlying cause, if it's AVM, if it's aneurysm, and so on. The eligibility criteria, and this is important because they could give you the complete description in the exam stem and ask you that if this patient can receive TPA or not. The time should be less than or equal to 4.5 hours from the onset. CT should exclude hemorrhage, and BP should be less than 185 by 110 before giving any TPA. Age doesn't have an upper limit, and the absolute contraindications are prior ICH, recent ischemic stroke of less than 3 months, then CNS surgery less than 3 months, active bleeding going on, platelets less than 100,000, INR greater than 1.7, for example the patient's on warfarin, SBP greater than 185 and 110 uncontrolled. Alright, now permissive hypertension in acute ischemic stroke with non-TPA, do not treat BP unless it's more than 220 by 120, right? Because elevated BP maintains perfusion to the ischemic penumbra, and for TPA candidates, lower BP to less than 185 by 110 before we give them any TPA. Alright, now moving up to the TIA, which is a trans-ischemic attack. We should know the ABCD2 score, because based on that we must, depends that what is the risk of the stroke in the next few days. Alright, it basically calculates the risk of stroke in the next 48 hours. So age is going to be 1, BP, so age more than 60, BP more than 140 by 90 is again 1, unilateral weakness is 2, speech disturbance only is once, duration more than 60 or equal to 1, equal to 1 hour. If duration is less, then it's 1 more point, so it counts to 3 points then. Alright, diabetes is 1. Alright, and the maximum score that you can get in this patient is going to be 1, 2, 3, 4, 5, 6, 7, 8, 9. That's out of 9. Alright, anything that's 0 to 3 is low, and it's about 1% chance of a stroke in the next 48 hours. Moderate is going to be more than between 4 to 5, and it's going to be 4% in the next 48 hours. Whereas for scores for 6 to 7, they're pretty high, and it's going to be about 8% in the next 48 hours. So we need to do immediate admission for those that have a high risk of for 6 to 7. All right. Now the management for TIA is going to be aspirin loading, which is 300 mg loading plus clopidogrel. All right, and this is given for 21 days, and this is known as the point trial. Now, if the patient has atrial fibrillation or the TIA is AF related, we give them a DOAC. All right, and then carotid imaging must be done if there is more than 70% ipsilateral stenosis. We have to do carotid endarterectomy within 2 weeks. All right, and this we give statins plus antihypertensive, and ABCD if it's less than 4, we admit within 24 hours. 6 to 7, we have to do an immediate admission. All right, so if let's say this is the stroke, which is the score for this patient, and it's less than equal to 4, we need to admit within 24 hours. Whereas over this and the score is 6 to 7, we just have an immediate admission. All right. Now moving on to the different headache syndromes, we have something known as the SNOOP4, which is the headache red flag. All right, and this means that S stands for systemic illness, N for neuralgia deficits, O for sudden onset or thunderclap headache, O for onset after 50, then P for postural changes, then P for precipitated by Valsalva, and P for progressive pattern, and P for previous headache changes. All right. Now those are the red flags that we must take into consideration for the patient that comes. Now there are different types of headaches. So migraine with aura especially. I've seen a lot of questions about migraine with aura and cluster headaches. I haven't seen the other ones, but they are worth giving a read for them. All right, because SAH is more important because it has a different protocol for treatment and the diagnosis of it. Now for migraine, we know it's unilateral throbbing. It may follow nausea, vomiting. The patient may have photophobia, and it may come with aura, and the aura could be visual zigzag. And the acute treatment is going to be triptans, somatriptans, NSAIDs, and antiemetics, whereas the prevention is going to be beta blockers, SSRIs, so amitriptyline and topiramate. Whereas for cluster headache, is going to be excruciating periorbital pain, and it's going to have autonomic features, and patient paces. It's 15 to 180 per minute. So it lasts 15 to 180 minutes. All right. Now the acute treatment is going to be oxygen therapy, because that's believed that it could be the reason because of vasoconstriction and less oxygen to the tissue. It leads to cluster headaches. Whereas the prevention is going to be verapamil first line. And prednisolone for a short course can be given to some patients with in their history. You have to check if they had a previous cluster headache and how was this treatment. If it did not have a good outcome with verapamil or NSAIDs or other drugs such as sumatriptan, then we can consider giving them a short course of prednisolone as well. All right. Now for tension headaches are bilateral pressing, mild to moderate, no nausea. So this is important because they're completely different from migraines. In the sense that they're bilateral, there is no nausea and not aggravated by activity. For these, we just give paracetamol and NSAIDs. Long term is going to be amitriptyline and physiotherapy as prevention. All right. SAH, it's the worst headache, and it appears in sudden seconds. In a few seconds it takes place. There's going to be neck stiffness, photophobia, and loss of consciousness. We have to get a CT of the brain done, and if the CT is negative, we move on to lumbar puncture at more than 12 hours for xanthochromia to confirm SAH. All right. Then for the preventive measures, you have to give them clips and coil to prevent the aneurysm again, and nimodipine. It's the drug of choice for SAH. All right. Then GCA, it's sudden, so giant cell arteritis. It's seen more in patients who are older, so more than 50 years old. It's more temporal headache with jaw claudication, and ESR has to be elevated between 50 to 100. Immediately, we have to give these patients prednisolone, 60 to 80 mg before biopsy if vision is threatened, because this could lead to permanent vision loss and vision damage as well. And then long-term treatment, we have steroid taper and monitor ESR. And the important fact is that for GCA, we have to use biopsy to confirm this diagnosis. But before the diagnosis, we can use prednisolone before the confirmation of the diagnosis, so that the vision can be saved. Now for SAH, the important fact is that the first CT is 90 to 95% sensitive at less than 6 hours. If the CT is negative but the clinical suspicion is high, we have to get a lumbar puncture done at minimum 12 hours after the onset for xanthochromia. And never discharge without LP if clinical picture strongly suggests SAH. Right. Now coming up to multiple sclerosis, this was a new topic that was seen more commonly in the February 2026 recall. It's a chronic autoimmune demyelinating disease of the CNS. At this point, if you've graduated university, you should know what MS is and how it develops and how does it progress, where does it start, and what's the normal pattern as well. And one of the presentation that the AMC likes to talk about is optic neuritis, and it's a presentation, and MRI is the key investigation for MS. So there's multiple focal demyelination of CNS white matter and disseminated in time and space. So multiple lesions at different times and locations. Typical patients are usually young, 20 to 40 year olds. Female to male ratio, so female are more affected by it than males, and more common in people of European descent, and higher prevalence in temperate climates. Optic neuritis is the classical first presentation where there is painful vision loss, pain on eye movement, and distinguishes from CRAO, which is painless. All right, it's going to be unilateral, and Marcus gun pupil can be seen where there's relative afferent pupillary deficit or defect. Then you'll see a central scotoma in a few patients. Color desaturation can be reported by the patients. Althoff's phenomenon is that the symptoms worsen with heat or fever. All right. Now the other common presentations are internuclear ophthalmoplegia, INO, with the failure of adduction of the ipsilateral eye plus nystagmus contralateral, which is the MLF lesion. Then Lermite sign is the electric shock sensation down the spine with neck flexion. All right. Then transverse myelitis, it's leg weakness, sensory loss, bladder dysfunction, cerebral ataxia, trigeminal neuralgia. And one more differential that you should always keep into consideration with leg weakness and especially sensorily or bladder dysfunction is going to be something called the cauda equina syndrome, because in that as well we have loss of bladder dysfunction. So we have bladder dysfunction is that, and they lose bladder control and with themselves. But the difference is that MS is going to be chronic, whereas the development of cauda equina syndrome is acute and it's an emergency. Right. Now there are a few different types. So remitting relapsing MS, it's the most common. An episode neurological deficit with recovery. Then primary progressive MS, it's uncommon, but it's steady worsening without any relapses. Diagnosis is done by MRI brain and spine, where we see demyelinating plaques, especially in the periventricular, juxtacortical, and infratentorial spinal cord, in the infratentorial and in the spinal cord. And the gold standard is MRI brain scan. All right, the MRI scan of the brain plus the spine. Then in lumbar puncture, we can see oligoclonal bands in CSF, which are IgG cells, and visual evoked potentials are another different test. And what is that? Is that prolonged latency, so delayed conduction through the demyelinated optic nerves. Then McDonald criteria is dissemination in space and time, so different parts of the body being affected at different time frames. All right. Treatment, especially for acute relapse, is going to be IV. So it's going to be steroids, so IV methylprednisolone 1 gram per day for 3 to 5 days. It speeds recovery, but it does not change the long-term prognosis for the patients. All right. Then disease-modifying therapies, so DMARDs are going to be interferon beta. I've not seen a lot of questions asked about the disease-modifying drugs, but just memorize them because they could come in the exam as well again, because we don't know what changes they're making in April. So let's see. So interferon beta, glatiramer acetate, natalizumab, fingolimab. You should just remember the first 4 ones, which is the most important, and those are the ones that are commonly mentioned. And ocrelizumab is also another drug, but I've not seen the last 2 drugs mentioned in exams. So it slows the progression, reduces relapse rate, and it has to be initiated by a specialist, because they could give you that, you're in a GP setting, you're not as a specialist. But remember that these drugs should be so these are the disease modifying drugs that are given for chronic and to reduce the progression and to give us better prognosis, but they can only be prescribed by specialists. All right, now the AMC key or the episode of the AMC patient profile that we'll have is a young woman with painful vision loss plus previous unrelated neurological episodes, so no aura with migraine, no stress, she does not smoke, and no alcohol, no history of hypertension, and so we have to consider MS until proven otherwise. So investigation is going to be MRI brain spine. VEP shows prolonged latency and not a CT diagnosis. Remember that. We tend to use CT for a lot of situations because the what do you call it? CT is more convenient, more faster, but MRI is the diagnostic definitive gold standard test for this patient. All right. Now, achalasia, the reason I included this in this neurology section, but not in the GA, it's also mentioned in the GA, but not in in depth, because it's a very small topic, and the main problem is neurological for achalasia, because it's a motility disorder where the lower sphincter or the lower part is not relaxing enough for the food to be able to pass through. So the classic symptom pattern is going to be liquids first always, then to solids. All right, whereas for carcinoma or mechanical obstruction is the other way around. So it's first solids, then to liquids, and there's going to be retrosternal discomfort and weight loss can be seen. Then the mechanism, so weight loss can be seen both in achalasia as well as in malignancies. So the mechanism is the degeneration of the Auerbach plexus, which are the inhibitory neurons. So LES fails to relax, and there's aperistalsis of esophageal body. Then in the diagnostic text in barium solo, obviously we'll see bird's beak or rat tail appearance in gastroesophageal junction with dilated proximal esophagus. Then manometry is the gold standard for these patients because there's going to be elevated LES resting pressure plus incomplete LES relaxation and absent esophageal peristalsis. Endoscopy is the first investigation for dysphagia in AMC context because you have to exclude malignancies at the gastroesophageal junction. And the characteristic pop can be seen when scope passes through the tight LES. All right. The treatment, there are multiple treatment modalities, but most of them are not consistent or don't give a chronic result, except for myotomy. Myotomy. So the treatment that we follow through first is going to be endoscopic pneumatic dilation, which is the first line. Then surgical Heller's myotomy, which is laparoscopic. Then botulinum toxin injections in elderly or or the patients that are unfit for procedure or they cannot handle procedures anymore. Then CCBs or nitrates have shown to help, but they're very temporary. All right, and so is botulinum toxins, but CCBs and nitrates are more temporary than botulinum toxins. Then the complication of achalasia is the increased risk of esophageal squamous cell carcinoma in the long term. So this is an important point because AMC does ask about this. Then the differential for achalasia must be esophageal carcinoma. But the difference between esophageal carcinoma and achalasia is going to be that carcinoma is solid first, progressive. It's seen in older patients with weight loss. Weight loss again is here. Then another differential should be GERD, where there's heartburn but not pure dysphagia. Then diffuse esophageal spasm, where there's intermittent chest pain. And the thing is that the whole esophagus is going to contract, and this gives a corkscrew appearance. Right, corkscrew esophagus. Then esophageal esophagitis. In this, we have young patients with atopy first, and then solid first with food impaction. All right. So AMC key is going to be liquids first, as achalasia or pharyngeal neuromuscular causes. Dysphagia to solid first is going to be to mechanical obstructions, and the distinction is the most tested dysphagia fact. And here we have the key numbers, and because the topic is really short, there are no MCQs in this topic. But if you have any questions, feel free to put them down below in the comment section below. It was a pretty short video, and hope this is enough to help you memorize or go over the high yield points for these topics. All right, have a good day. Thanks for watching. Bye.